Good evening, everyone. I'm Tony Segreto, and once again, so honored to be your moderator for tonight's In the Know Town Hall. We welcome you to our continuing series that we call The Science of Aging. And tonight, we're going to be talking about our brain health. As you know, the brain is one of the most complex organs in the human body. But as mysterious as it is, our physicians are continuing to make extraordinary advances to combat the impact of some of the more common brain disorders, specifically cutting edge therapies for stroke, Parkinson's disease, and epilepsy, among others. Tonight, and I stress here again, brilliant, brilliant minds from the Miller School Department of Neurology will help us explore these topics. They will share the latest information on treatments and cures for common neurological problems. Our panelists tonight include several renowned experts in neurology. Dr. Ralph Sacco, who, in addition to being the chair of the Department of Neurology at the Miller School, also holds many other roles, among them executive director of the Evelyn F. McKnight Brain Institute and chief of neurology service at Jackson Memorial Hospital. Dr. Sacco is an expert in stroke prevention, treatment, risk factors, and vascular cognitive impairment. He will take part in the question and answer session tonight with Dr. Itasham Huq, who is the chief of our Movement Disorders Division and director of our Parkinson's Disease Foundation Center of Excellence. Dr. Andreas Kanner, chief of the Division of Epilepsy and the director of the Comprehensive Epilepsy Center. And Dr. Erica Marulanda, who is the assistant professor and member of the Comprehensive Stroke Center at Jackson Memorial Hospital and the Primary Stroke Center at UHealth Tower, as well as the director of our Jackson Neuro Hospitalis section. As you can see, it is truly a world-class group of experts. Sometimes, what do we like to call it? The Mount Rushmore of experts. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Sacco has delivered his opening remarks, the panelists will answer the questions that you've submitted over the last few days. But you're also going to have the opportunity to submit questions during this program. For those of you who have been with us before, you know the drill. For those of you who are new, at the bottom of your screen, you'll see a Q&A feature. That's the feature you'll use to send us your questions. And a reminder again to everyone sending us questions, every one of the questions will be anonymous. And I promise you, we will get to as many of them as we possibly can. So we have a full plate, a full program tonight, so we're not going to waste any time. It is now my pleasure. Dr. Sacco, I know how busy you are. What an honor to have you here tonight along with the rest of your team.
Well, thank you, Tony. Good evening, and appreciate being here with you again. It's really terrific and fun and important to get the word out. I'm really proud to represent the Department of Neurology at the Miller School. We're one of the premier departments in the country with renowned research and clinical faculty in almost all of the neurological subspecialties. Their skill and dedication is what really sets us apart. So I'd like to first acknowledge our leadership and faculty members who are joining us tonight. They're truly dedicated to advancing the neurological health of our community. Just a few months ago, we gathered here to discuss things we can all do to protect our brain health and prevent aging of the brain. This is important because people are living longer as medical advances are increasing our lifespans. That increased longevity is creating an epidemic of neurological disease. In fact, 1 in 6 have neurological conditions, and we're going to hear about some of those common ones tonight. 1 in 3 people in their lifetime will have a stroke or dementia. So tonight we're going to focus on what happens when you're diagnosed with the neurological disease and the incredible treatment advances we are making to some of the more common disorders. Real common ones: stroke, epilepsy, seizures in epilepsy, and movement disorders, and particularly Parkinson's disease. These are some of the real most common neurological conditions. So we're lucky to have Dr. Huq here. As Tony just mentioned, he joined UHealth recently and is an expert in treating Parkinson's disease. He's going to talk about the innovations like deep brain stimulation and how that is being used to control and lessen patients' tremors with Parkinson's, improve their ability to walk, and also make a difference for other patients with Tourette's syndrome and even obsessive compulsive disorder. We also have Dr. Kanner. He's a renowned expert in epilepsy and seizures control. and we'll share the latest clinical trials and treatments in that field, including how we can really cure epilepsy with laser surgery and control seizures with with new innovative implantable devices. Our final panelist is Dr. Marulanda, who, like me, focuses on treating and preventing stroke. She will tell us about the life-changing treatments with brain catheters that can pull clots out of arteries in stroke patients and clotbuster medications that can reverse the consequences of stroke. There's a lot we can do for stroke and stroke and other neurological conditions that you're going to hear about tonight. My expertise is in stroke prevention, so hopefully we'll handle some questions on what do you do to prevent a recurrence and how do you prevent stroke in the first place. I will share with you what we're doing to address acute stroke treatments in the state of Florida as the coordinating center for the Florida Stroke Registry. So we're really thrilled to be here sharing this information with everyone tonight and look forward to your questions. Tony, back to you.
Yeah, this is going to be a night that's going to fly by this next hour. So let's turn to the questions now that you've submitted. Our first question is for you, Dr. Huck. What are the most recent advances for common movement disorders?
I think that's a wonderful question, and I'll try to be brief. There's so much that's going on right now. I think that one of the biggest advances that we have recently is the ability to start to treat some things that are caused by genetic disease, particularly things that are caused by one gene, like some kinds of ataxia and some kinds of Huntington's disease. Although these are not the most common disorders, the idea that we can cure uncurable diseases is a very powerful one, and so gene therapy has a lot of promise there. I should devote most of my time to talking about Parkinson's disease, since that is the most common thing that we treat and what people most commonly have. There are fewer new things, but there are new things. There is stem cell therapy, which I think a couple of other questions I'm sure we'll deal with today. Those are just in early days, those trials, and people can both inject stem cells and take them intravenously. That's showing some promise, but that deserves, I think, a bit more discussion later on down the line. That's early trials there still. I think our most exciting therapy is the one that Dr. Sacco has already mentioned, deep brain stimulation therapy. That's where we go when the medications no longer do quite what we need them to do for our patients. It's essentially a brain pacemaker, and the ability to change the way the brain works with a touch of some buttons and to continue to do that on an ongoing basis is a powerful technique with a lot of applications. So that's a very quick thumbnail overview.
Dr. Huck, thank you. Dr. Sacco, what has the University of Miami been doing to help improve acute stroke care across the state of Florida? You mentioned it sort of in your intro, and improve health equity.
So I'm proud to talk a little bit about our Florida Stroke Registry. It started with NIH funding. We put in a grant and were awarded a grant to really develop the Florida Stroke Registry. And the goal was to develop not only a registry across the state, but to focus on reducing stroke disparities. Disparities by race, ethnicity, region, and even gender, men and women. So we created the Stroke Registry, and right now I'm happy to say that the work has been funded by the Department of Health in the state of Florida, and we have about 130 hospitals collecting information on acute stroke, how quickly they can give certain clot busters that we'll talk some more about, how much they give the catheter device, endovascular therapy, what they do in terms of other medication use, and how much what we call defect-free care, following the guidelines and doing almost perfect care for acute stroke. So we've created what are called dashboards, stroke dashboards that compare white, African American, and Hispanics at each hospital. And these hospital disparities dashboards can be used as tools to share best practices, to really raise the bar and improve the care for everyone, regardless of region, sex, race, and ethnicity. And you can't imagine how great the care is going. When you look over time, and we can look at time in all of our centers, the amount of disparities has been reducing. The more you follow evidence-based guidelines, the less disparities you see, and people are getting really high quality acute stroke care in the state of Florida. So I'm happy to be the director, working with a great team at the University of Miami to raise the bar for all stroke across all individuals in the state of Florida.
Herculean initiative for sure, Dr. Sacco. Thank you. Dr. Marulanda, welcome. It's nice to have you with us tonight. Can early treatment reverse the effects of a stroke?
Absolutely. And that's such an important question. About 30 years ago and even 10 years ago, stroke was a diagnosis that was kind of felt to be futile. If you had a stroke, it was thought that that was that. But that has changed significantly. Now we have a lot of ways to treat strokes, and the symptoms of a stroke can be reversed. And we have a saying that time is brain. And that saying is so important that we've included that into our acronym that helps us recognize the signs and symptoms of stroke. So that acronym is FAST. F is for face, A is for arm or leg, S is for speech, and T is for time, to remind people that time is brain and that it's time to call 911. So if people are having symptoms of a stroke, it's crucial for their family members or people around them to recognize those symptoms, because time is so important. A stroke is a blockage of, or one type of stroke is a blockage of an artery in the brain. And the faster that you can remove that blockage, the faster that you can get blood flow to the brain. And if you normalize that blood flow, you can get that tissue active again. And the faster you do that, the better the chance of a full recovery. So it's absolutely crucial to treat as fast as you can. In a lot of cases, you can reverse the effects of a stroke fully. So again, time is brain. That's crucial to remember.
Dr. Marulanda, thank you. Dr. Kanner, we just had this question sent into us. Have you done any research with Lyme and epilepsy? And if so, what have you learned?
I personally have not done any research with Lyme and epilepsy. Lyme can be associated with an inflammation of the brain, which it can at times result in the development of epileptic seizures. It's not a frequent cause of epileptic seizures, and I personally don't think that I've ever seen a patient with epileptic seizures that had been attributed to Lyme, but any condition that is associated with inflammation of the brain potentially can result in epilepsy and the development of seizures. And the treatment, if that were to happen, obviously is you treat the underlying condition and you start medication to prevent the recurrence of the epileptic seizures.
Thank you, Dr. Kanner. Dr. Huck, you touched on this briefly when we asked you our first question. What can help treat Parkinson's disease, stem cell or gene therapy?
I'm so glad for this question because it lets me expand on some things that really ought to be expanded on. So the short answer is both are very promising, but neither really is ready for prime time. Now let me give you the slightly longer answer. To understand what is going on with stem cells, the first thing is to understand what stem cells are. Briefly, stem cells are cells that have not yet grown up into one or another. They're cells that don't yet have jobs, or cells that have not differentiated, to use our terms. The difficulty is getting those stem cells to grow up in the right way without the influences that are normally there. In other words, we are no longer babies. And so all those things that are fetuses, even those influences that help those cells grow into what they ought to, are things we have to duplicate when we provide those stem cells to individuals, or we have to have some way of having the body mimic that. So just injecting stem cells into a person is something that has not shown a lot of benefit. And so I definitely want to caution patients about going to some of these stem cell shops that have been set up both in Florida and abroad. If you are going to a place that's charging you a lot of money in order to put stem cells into your arm or into your leg, there really isn't any evidence that it helps a whole lot. Trials are ongoing. We're excited about where those trials can go, but they haven't gone there yet. As far as the second part of that question, gene therapy is very exciting, but what gene therapy does is allow you to sort of overwrite what a gene would normally do. So it works best when you have a disease that's caused by just one gene. And Parkinson's, unfortunately, is not usually that kind of disorder. We have some hope for gene therapy for those folks who have monogenetic one gene disease. For other folks, well, genes are also risk factors. So we hope to use genes not so much as treatment, but as ways to identify who might be at risk for disease so that we can identify it early and do something to change the way their course progresses.
Thank you, Dr. Huck. Dr. Kanner, under what circumstances is a patient with treatment-resistant epilepsy a good candidate for epilepsy surgery, and what percentage of those patients achieve a seizure-free state?
Yeah, that's a very important question. Epilepsy is a condition where approximately 60 to 70% of patients can be expected to have remission of their seizures completely with medication. Unfortunately, 30 to 40% will continue to have seizures despite several trials of antiepileptic medications. In those patients, we do an evaluation to establish where do the seizures originate from in the brain. We perform a continuous EEG monitoring study, record their seizures, and establish where those seizures are originating from, and determine whether the removal of that part of the brain that is generating the seizure is a short circuit, can be performed safely. In other words, whether this area is not in charge of certain important functions of the brain, such as speech or the motor cortex or visual cortex. So if it's coming from areas of the brain that can be safely removed, like the temporal lobe in the non-dominant hemisphere, for example, you would be a good candidate for surgery. In those patients that are candidates for surgery, the expectations that patients can become seizure-free ranges from 50% to 70%. And that changes dramatically the life, the quality of life of the patient. An additional 20% can expect to see a significant reduction in their seizure frequency. And in remaining 10%, the surgical procedure may have no impact.
Dr. Kanter, thank you. Dr. Sacco, what are some of the research projects going on right now at the Miller School of Medicine to improve stroke treatments?
So there are many projects that we're involved with. So first, we are what's called the StrokeNet Coordinating Center for the state of Florida. When NIH wants to do trials, cutting edge trials for prevention, recovery, or acute stroke treatment, they'll go to these regional coordinating centers. And in the state of Florida, we coordinate many other centers that are in the state to look at some of these trials. So things like obstructive sleep apnea, what's the best way to treat it after stroke? Using statins, should we restart statins in certain people who have certain kinds of stroke with hemorrhage, or even blood thinners that say are used to prevent stroke with atrial fibrillation, but somebody has bleeding in the head, maybe should they still be on a blood thinner or not? Variety of programs. Dr. Romano's project is looking at predictors for why people get worse when they have intracranial narrowing of the arteries inside their head. We're also involved with studies for carotid angioplasty and stenting and endarterectomy, particularly for asymptomatic carotid disease in these big NIH-funded studies. There are so many unanswered questions, and we're trying to be part of the teams that help provide new answers. Some cutting-edge work in animal studies that we're doing, and even some work, as Dr. Hawk mentioned, in stem cells for stroke that are being looked at in both animals, small and large animals, as well as beginning to be looked at in humans. So it's great, and I'm proud to be working with a lot of wonderful colleagues at the University of Miami in some cutting-edge stroke clinical research.
Cutting edge indeed. Dr. Marulanda, how do doctors find a clot in the brain?
Sure, that's a great question. So if somebody's coming into the hospital with symptoms of a stroke, everything is done very quickly. It's an emergency. We call something called a stroke alert. And so we have to have imaging that can be done very quickly as well. One of those types of imaging that we can do is called a CTA, short for CT angiogram. It's a kind of CAT scan that uses contrast that's injected very rapidly into the vein that highlights all of the arteries in the neck and the head that helps us find a clot. So it highlights the arteries, and wherever there's a blockage, the contrast won't pass through that area, and then we can tell that there is a blockage in that part of the brain. So that helps us know that that's an area where blood flow is not passing. If for some reason that test is not available, there are other kinds of tests, for example, an MRI or an MRA specifically, that can help us look at the arteries as well. In non-emergency settings, we can also use ultrasound to help us look at the flow of arteries in the head and the neck to help us find clots in the brain as well. So there are a lot of different modalities that we can use. And sometimes to make clinical decisions, we like to use more than one to be sure if there is a clot or not. But the most common type that we use is the CT angiogram because it's the fastest and usually the most reliable.
Right. And doing it that quickly is paramount.
Exactly. That's the most important factor.
Dr. Huck, why isn't deep brain stimulation, otherwise known as DBS, used more often if it appears to work so well?
That's a good question, Tony. I think we should be using it more often in Breathe. So what deep brain stimulation is the placement of essentially a pacemaker into the brain. So there are electrodes that go deep into the core of the brain, hence the name. It's all internal. The wires, after they exit your skull, go underneath your scalp, over your collarbone, and down to what's essentially looks like a pacemaker generator in your chest. And those devices can do a lot of things these days. They've developed devices that can be programmed remotely, so you don't have to come into the office. You can be programmed from 2 or 3 hours away. And we've been actually among the first. We have been the first in Florida to implanted the most of those at any other center. There are devices that can do very fancy things with the way the electricity travels. We implant those as well. There are even now devices that will read your brain waves and allow us to adjust the stimulation to what your brain is actually doing. The thing is, deep brain stimulation still involves a brain surgery. As brain surgeries go, it's a pretty safe one, but pretty safe is a relative thing. So it's something that should be considered carefully by folks, but there are folks who have too many issues, perhaps with bleeding risk or infection risk, for DBS to be useful for them. But honestly, for most patients with Parkinson's disease, whether or not to choose DBS will be a discussion that they eventually have with their physician. It's perfectly fine to decide that it's not right for you, but I think there are plenty of people who would benefit from it who don't even get to hear about it.
Dr. Huck, thank you. Dr. Kanner, this was just sent to us. What epilepsy centers are available that would offer implantable devices for patients with epilepsy? And are there specific types of seizures that lend themselves to such devices?
Yes, well, I'm proud to say that the UM is one of the centers that implants these devices. And our center actually implants all 3 devices. One is the deep brain stimulation that Dr. Hag was referring to. And in fact, we share the same neurosurgeon to do implants for DBS for Parkinsonian patients and for patients with epilepsy. These implants are used for patients who are not candidates for resective surgery, but have transformed the treatment of these patients because with the use of these devices, there can be a significant reduction in the seizure frequency of these patients. So the DBS targets a different structure in the brain than for Parkinson's disease. It targets the thalamic nuclei. And this is used for patients with intractable epilepsy of frontal lobes or where we cannot localize properly the seizure foci. We have the responsive neurostimulation, which is a device that is implanted under the skull and it's connected to the area of the brain that is generating the seizures. And this is used for people where seizures originate in more than one area of the brain that obviously we cannot operate on 2 areas of the brain, or is it originating in an area of the brain that cannot be removed. One of the electrodes record the electrical activity and a computer chip embedded on the stimulator detects when the seizure activity is occurring and it sends an electrical stimulation to stop the seizure. In those patients, we're seeing 80% in seizure reduction and in about 15 to 20% patients have become seizure-free for at least a year. And then the other device is the vagal nerve stimulator, which is the oldest device that is available. And that is placed under the clavicle and is connected to a nerve in the neck, the vagal nerve, which is a highway to the brain, and it sends electrical stimulation at a constant rate. That electrical stimulation decreases the excitability of structures in the brain and in that way decreases the seizure frequency. So we have the University of Miami that does all 3 devices, You can also have the devices implanted as far as now at the Cleveland Clinic, at Memorial Hospital here in South Florida. In the northern part of the state, the Mayo Clinic has it, and the University of Florida in Gainesville.
Fascinating. Dr. Kanner, thank you. Dr. Sacco, this was just sent to us. I suffer from headaches in front of my brain every single day. I had it for several years now. Medication doesn't help. Does lack of sleep cause this? Do you have any suggestions?
So first of all, you've hit on what is the most frequent disabling condition in neurology, which is actually headaches. Headaches are a big problem, and there are many different kinds of headaches, tension headaches, as well as migraine. The good news is we have so many new medications, especially for migraine, that now have been approved and are really quite effective in reducing migraine frequency and the disability related to migraine. In terms of the question about sleep, we also have some cool and important sleep experts at the University of Miami, and sleep disorders are quite frequent and can cause many repercussions. Can even increase the risk of stroke if you have obstructive sleep apnea. But yes, lack of sleep can contribute to headache syndromes. I think it's best to kind of get evaluated by one of our neurologists, either one of our headache experts. Tisha Monteith is our headache chief, or our sleep program. Dr. Dibb and Dr. Ramos are the key leaders of our sleep program. Headaches are complicated, and sometimes taking too many medications, what we call over-treatment or over-medication headache, can make things even worse. So often important if you're having these kind of severe headaches to get to see a neurologist.
Thank you. Dr. Marulanda, what is a stroke or brain attack?
Sure. So there are different kinds of strokes, and I kind of alluded that a little bit earlier. So the most common one that we hear about is an ischemic stroke. So that's the kind of stroke that happens when there's a blockage to an artery in the brain. That can be one of the larger arteries or a smaller artery. And when that happens, there's lack of blood flow or oxygen to that part of the brain. And those are the types that I was referring to when we can use medications to break up clots to treat that, or when a doctor can go in and take out a blood clot. So that's an ischemic stroke. And that's the most common type here in the US. Then there's another category of stroke that are called hemorrhagic strokes. That can happen when a blood vessel bursts in the brain and can cause bleeding. There are two causes of that. That's when an artery bursts. And there's also a type of stroke called a subarachnoid hemorrhage, when an aneurysm or a bubble forms in an artery and you can have bleeding in the brain related to that. It's important to know that high blood pressure is a huge contributor to all kinds of strokes, to all of those kinds of strokes that I mentioned. Another thing that I want to mention is that people hear about transient ischemic attacks, or TIAs very commonly, also called mini strokes. So those are ischemic events, and those are ischemic events that don't leave a mark in the brain. But they're very important, and they have to be taken very, very seriously, because if you have one of those, that means that you're at risk for a stroke, and the symptoms have to be taken very seriously. And the evaluation for that is exactly the same as you would have for a stroke. We do the same exact tests as we would for a stroke, and they have to be done as soon as possible because it's a high risk event. It means that you're at risk for a stroke, and the high risk period for that is really at highest within the first 24 hours. So it's very important to get evaluated for that as soon as possible and not put that evaluation off.
Great advice. Thank you, Doctor. Dr. Huck, this is another one just sent in, and we're getting so many questions, so we're going to get to as many of them, we promise, as we can. The question goes like this, Dr. Huck. My wife suffers from progressive aphasia. She's had it for almost 2 years now. We would like to know what advances, if any, have been made toward treating aphasia and/or restricting its progress.
First off, I wish my very best to you and your wife. Aphasia is a tough thing to be dealing with. One of the key things to do first is to make sure the diagnosis is solid. I have no doubt that it is, just speaking from a sort of pedagogical standpoint. There are a lot of things that can lead to a person having progressive difficulty with speech. So you'd want to really make sure that other potential causes of it, besides the condition caused called primary progressive aphasia have been ruled out. For example, small strokes in the right place over time could impair your speech. There are psychiatric conditions that could do it too, but there very much is an entity called primary progressive aphasia that falls into Parkinson's-like conditions. This is a condition in which a particular protein builds up in patients' brains, in the part of their brain that helps them produce speech. And the main symptom is just not being able to talk when you want to talk. And when you do talk, often the speech does not come out quite normal. The kind of protein that is accumulating is a protein called tau. And so there's a lot of overlap with something called progressive supranuclear palsy, and also with Alzheimer's disease, both of which are also diseases in which this protein is accumulating. Although a number of treatments have been tried to go and attack tau, unfortunately, those have not been very successful yet. So we recently had a relatively disappointing outcome on an anti-tau trial for PSP. So I think scientists are sort of going back to the drawing board to see what the best way to attack things like primary progressive aphasia might be. So although it's an area of hot interest, unfortunately, we don't have new treatments to offer to people today.
Thank you, Dr. Hug. Dr. Kanner, what is the role of laser ablation in epilepsy surgery, and can it replace certain types of resective surgeries?
Yeah, that's a great question. And it's an important area that has revolutionized the way neurosurgeons perform epilepsy surgery. Laser surgery is a procedure whereby the neurosurgeon inserts a laser probe, which is a 1.5 to 2 millimeter thick device under MRI guidance to the area of the brain that is generating the seizures. Typically, we use it in people whose seizures originate in the temporal lobe, in the structures, the amygdala and the hippocampus of the temporal lobe. And though the laser will burn those structures and will, after this procedure is done, the neurosurgeon removes the probe and the patient goes home the next day. This has been replacing the patients with temporal lobe epilepsy whose seizures originated in those structures, in the amygdala and hippocampus of the temporal lobe. And in a recent study that we just concluded, and we analyzed our data in close to 50 patients that were performed at our center, the outcome of these laser ablation is comparable to that of a temporal lobectomy in patients whose seizures originate in the mesiotemporal structures where there is what we call hippocampal atrophy, that is a scar. So that's a very exciting finding because obviously patients come in on Wednesday and they go home on Thursday. They don't even spend the night in the intensive care unit, and they go back to work the following Monday. This strategy is also used to treat what we call focal dysplasias, which are malformations of the cortex that are small malformations where you also burn those structures, and the same approach is followed. The trick here is being able to evaluate the proper patient for the procedure. And if you're able to evaluate the proper patient, the benefits are significant. The other side of the coin is that if the patient continues to have seizures after the laser ablation, they still can be a candidate for a temporal lobectomy, which requires opening of the skull and removing a larger part of the temporal lobe.
Thank you, Dr. Kanner. Dr. Sacco, can the brain repair itself after stroke damage causing loss of peripheral vision?
So that's a great question. You know, we are still years away from making market advances in stroke recovery. People do recover, and often the recovery can be early. Motor recovery is usually in the first 30 days. Speech can continue to recover for years. Vision is tougher. When you have a stroke in the back of the brain where, say, part of your vision will be out, there have been some restorative and rehabilitative programs to train the brain and train the eyes to continue to see better. And even people have tried to use computers and mirrors, but it's still hard to get the brain to, actually repair that area of injury, particularly vision. I think there are other areas of the brain where some restoration and recovery occurs more with what we call functional reorganization. The brain begins to kind of reorganize some of the pathways. Unfortunately, vision is still one of the tough ones, but I think working with some of our experts and Baskin Palmer and some other neuroscientists, there are some, potential advances in the future to help the brain recover vision in those that have a stroke that takes out vision in one side of the brain.
Thank you, Dr. Sacco. Dr. Marilanda, I know you touched on this, but if we can go a little bit further into it, what are the latest advances in stroke treatment?
Great question. So I think one of the important things to mention is that telehealth and telemedicine has brought stroke treatment to many people that didn't have access before. So that's a huge advancement. I think in Miami, we're lucky to have access to stroke treatment, but we have to think about the rest of the country. So that's a huge advancement. Some other newer things are that, we've had thrombolytics or clot busting medications around for at least 25 to 30 years, but we were using the same medication for a long time. Now we have newer medications on board that we have access to that are useful in different ways, and now we have access to. We also have access to endovascular treatment, which is what I mentioned before, which is when the neurosurgeon or endovascular specialist can go in, and once we diagnose the clot in a specific location, they can use a catheter to suction out or remove the clot from the brain and reestablish blood flow to the brain. Other advances are that we can use imaging, so a CT angiogram, more advanced, which we call CT perfusion, to help us determine exactly which patients are going to benefit from having these procedures. So as I said before, time is brain, and we hope that everyone will come in as soon as possible, but unfortunately that's not always the case. So some of the biggest advances that we've made in the past couple of years is using these imaging technologies to help us choose the right patients. And even if you come in, even 24 hours out, these imaging technologies help us determine who will benefit even very late in the game. We have other things kind of in the pipeline, including studies looking at using stem cells and other medications to see if in the future we could have patients benefit from treating them acutely along with these other treatments, but that's still to be seen. But the good news is that there are a lot of advances happening and a lot of things in the pipeline to try to help our patients suffering from acute stroke. So it's a very exciting time for stroke care.
Exciting indeed. Dr. Huck, we're going to go back to DBS here for a moment. The question goes, how many deep brain stimulation procedures are performed each year at your hospital?
It depends on the year, but we typically will perform between 50 and 80 lead implantations each year. That's for Parkinson's, essential tremor, dystonia, for the movement disorder indications. If we count Dr. Kanner's, I imagine numbers would be slightly higher.
Thank you, Dr. Huck. And Dr. Kanner, we just had this one sent in. For someone who has failed a right temporal lobectomy and still has a bit of the hippocampal tail that can't be surgically removed, what surgical options other than VNS are there for those patients?
So if you've had a temporal lobectomy and you can identify a residual tail of the hippocampus in the area where you had the surgery, and you can demonstrate that the seizures are still coming from that region, you could consider using laser ablation to burn that tail of the hippocampus, or you can do an evaluation and establish whether the seizures are coming from structures that are adjacent from the areas that were resected. And particularly in the right temporal lobe, if it's a non-dominant hemisphere, you can do more extensive resections because many areas of the right temporal lobe are non-eloquent. And this is something that can be done with intracranial electrodes and map the exact region of the right temporal lobe that is generating the residual seizures, and identify also areas adjacent that could be mediating eloquent functions, and then plan the surgery accordingly. If the area of the brain that is generating the seizures goes beyond resectable areas, or laser ablation is not an option, then the use of a responsive neurostimulation is a very good option that can be placed where the stimulator is placed under the skull and the electrodes go to the areas of the brain that you've identified as a generator for the residual seizure activity.
Thank you, Dr. Kanner. Dr. Sacco, the last question we asked you, we talked about motor skills and vision, and we talked about speech. So the question that was sent in is, are there ways to reverse cognitive impairments with therapies, vitamins, and/or medications?
So cognitive therapy is tricky. So first of all, people who survive a stroke are at high risk for cognitive impairment, something we call vascular cognitive impairment. And in fact, we're part of a big nationwide NIH-funded study called Discovery, which is trying to look at cognitive outcomes and the predictors of poor cognitive outcomes after stroke. In terms of cognitive disease or cognitive change post-vascular disease, there are three things that I would say are important. One, what we call cognitive rehab or cognitive exercises. Some of it may be doing crossword puzzles to working on the computer, staying socially integrated and active. Those things can help the neurons, the brain cells continue to work and connect. Physical activity has been shown to continue to improve, reduce cognitive decline. And then I think the last thing would probably be control of blood pressure. Blood pressure is a big one. There are many studies that have shown that high blood pressure can worsen cognitive decline. So making sure your blood pressure is controlled with either medications or with diet and exercise, and keeping those under control. Vitamins, it's trickier. There's many different vitamins out there, and there's talk about, vitamin B, vitamin D, vitamin B12, but a lot of it isn't totally proven. We're still a long way, for example, for treatment with Alzheimer's disease and other cognitive impairment. But cognitive exercise, physical exercise, and keeping your blood pressure controlled are three things that can make a difference.
Thank you, Dr. Sacco. Dr. Marulanda, are there accurate DNA tests for these brain diseases? Is there diagnosis that can be made? And I know you talked about scans, but this question specifically asked for the PET or the MRI scans.
Sure. So in terms of DNA testing, I think it's important to distinguish between screening tests that people take when they're curious about diseases that may be predisposed to, kind of tests that they can take, that they can buy online and just say, what kinds of things am I predisposed to? If it comes up that you're predisposed to, or that you have the gene for Alzheimer's, that doesn't mean that you're going to develop Alzheimer's if you have no symptoms. There are many different factors that play a role into that. Now, if you have symptoms of a disease and we're doing genetic testing to help us come to a diagnosis, that's a very different situation, like Dr. Hawk mentioned, where there are some genetic tests for some of the conditions that we look for. That's used in conjunction with your clinical history, your physical exam, your imaging to come to a diagnosis. So for example, there are some stroke syndromes that are genetic, in which patients have strokes at a young age, in which we do have some genetic tests that help us come to a diagnosis. There are some genetic testing that's used in Parkinson's, in the different ataxias, in childhood epilepsies that help us clinch a diagnosis. But in general, it's rarely used alone to come to a diagnosis. So that's why I mention these kind of genetic tests that are looking for everything and anything, because those are not, I would say those are not accurate in looking for brain disease, because there are a lot of different factors. Brain diseases, are multifactorial, and it's not that one gene causes one disease. A lot of different things have to happen in order for diseases to develop. There's environment, there's your genetics, and a lot of different processes. And so it's important to consider all of that. In terms of the imaging, again, imaging is one part of how we come to a diagnosis. That's why neurology is so complex. And I think that's why we all enjoy the practice of neurology so much. A lot of it is the clinical history, and the imaging helps us come to a diagnosis. So for example, in the movement disorders and in Parkinson's, we use SPECT imaging or DOT SPECT imaging to help us come to a diagnosis in the different types of Parkinsonism. We use SPECT imaging sometimes to help us decipher between infections and tumors when we have an MRI where we can't be sure what the lesion is. So we use imaging in a lot of different ways, but not just in an isolated way to come to a diagnosis. We have to use everything put together to make a clinical decision.
Great. Thank you, Dr. Marulanda. Dr. Huck, we just had this one sent in. How can I increase BDNF and decrease MAO-B for Parkinson's?
So BDNF is a bovine-derived neurotropic factor, and MAO-B is one of the important enzymes that helps control how much dopamine there is in your brain. To give folks a brief primer. BDNF looks like it's important for growing lots of different cells in culture. MAO-Bs help keep Parkinson's medications around a little bit longer. Let me take each of those individually. With BDNF, there really isn't any clear indication that raising your levels would help. Parkinson's, like most neurology, is a very regional illness. Things have to happen in particular places. If there was a strategy that increased BDNF, and it's not clear that there would be one anyway, it would increase it globally. And you do not want all parts of your brain growing as rapidly as possible. That's a quick trip to cancer. Not that BDNF would cause cancer, but just describing what that kind of approach in general is probably unsound. Second, the way people typically try to increase BDNF, unfortunately, is by trying to eat it or eating something that supposedly increases it. Unfortunately, I mean, it's the job of your gut to break stuff down so you can build it back up. So that BDNF ends up being sort of an expensive source of protein for most people. So as you can tell, I'm a little dim on how much BDNF can help. It helps cell cultures, but we haven't yet seen a way that it can help people. I'm hopeful that eventually we bridge the gap. We have not bridged that gap yet. Now, the MAO-B strategy is a very useful one that we use all the time to keep dopamine around. The important bit of background there, as I think a lot of people will be aware, but still worth stating, is that a lack of dopamine is responsible for most of the symptoms of Parkinson's, as far as we know. So taking an MAO-B inhibitor will help keep more dopamine around. Okay, so that means it'll help your symptoms if you have Parkinson's disease. But unfortunately, there's no evidence that increasing MAO-B prior to developing symptoms does anything. MAO-B inhibitors were looked at specifically to see if they slowed down progression of Parkinson's disease. And unfortunately, I say unfortunately, because it didn't hold up in subsequent trials, there's a lot of excitement about a trial that seemed to show that an MAO-B inhibitor called rasagiline slowed down Parkinson's a touch. Subsequent trials seem to put that to rest. Unfortunately, MAO-Bs at this point in time cannot be said to slow Parkinson's disease down. So that's another strategy that has a lot of potential benefit if you're being treated for Parkinson's disease, but I wish I could say it slowed Parkinson's progression down. And in fact, it can have some dangerous interactions, MAO-B inhibition with other medications that a person might be taking, or even cause strange reactions to things like eating cheese or drinking wine. So in short, although I actually encourage people to read and consider alternative strategies, at this time, neither BDNF nor MAO-B is something I would advise for my patients.
Dr. Huck, thank you. Dr. Kanner, how do you determine stroke versus seizure?
So the diagnosis or the distinction between stroke and seizure is based on the clinical presentation primarily. The seizure is a very short event. Usually a seizure lasts anywhere between 45 to 60 seconds to up to 3 minutes. A stroke is a much longer event, and very often there can be confusion because when you have a seizure, and if the seizure is not witnessed, and it's coming, let's say, from the left side of the brain, close to the frontal region, when you recover from the seizure, you can be left with transient weakness of the right side and inability to speak. In those situations, if the patient is identified at that stage, it may appear as if the patient may have had a stroke, particularly if the recovery, the motor recovery or the recovery of language takes a longer period of time. And in those cases, you will use neuroimaging studies to rule out the presence of a stroke, like Dr. Marulanda was describing. And you use electroencephalography test, which is a test where we look at the electrical activity of the brain, trying to identify abnormal electrical activity that is indicative of having had a seizure. Sometimes these tests are negative, and you basically have to go by your clinical data in order to reach a conclusion. But these are questions that eventually you come to an answer in most cases. I think there are situations when patients have a transient event of weakness or loss of language, and a stroke alert is called, and those patients are being evaluated for an acute stroke. They're found through the CTA and the other evaluations not to actually have had a stroke, and in those cases, we do an evaluation to establish whether they may have had a seizure that may not have been witnessed, and during the postictal period, that is after the seizure, they were left with that deficit that is transient.
Thank you, Dr. Kanner. Dr. Sacco, this was just sent to us. What can be done for prophylactically to prevent stroke?
So prevention is big, especially in stroke. It's one of the key areas for neurological conditions that we can do something about. The thing that we created with the American Heart Association was Life's Simple Seven. 7 key factors that are important for promoting ideal cardiovascular health. 4 of them are behaviors, 3 of them are numbers. So blood pressure, cholesterol, and your blood sugar. So high blood pressure, diabetes, and hypercholesterolemia, they can be treated with medications. Know your numbers, get them under control, and that can have a major effect on reducing the risk of stroke. 4 of them are behaviors. Don't smoke, never smoking. Diet, following the American Heart Association diet. Obesity, keeping your weight down, and then the importance of being physically active. Physical activity is another important one. So if you can follow the ideal cardiovascular health, those 7 key factors, and get yourself into ideal health, you can really make a major difference in terms of preventing stroke, as well as improving brain health, vascular cognitive impairment. So I think what's great about stroke is there are many things we can do to keep your brain healthy, prevent a stroke, and also prevent cognitive decline with age.
Great, Dr. Sacco, thank you. Dr. Hawk, this was just sent in to us as well. What are the best options when the carbidopa begins to lose its effect with Parkinson's PD dementia patient? And how do we best address Parkinson's freezing rigid episodes in later stages of this disease?
So those are 2 really big questions, both in the field and that we deal with on a daily basis with patients. So to take them separately, what do you do when carbidopa-levodopa loses its efficacy? The tricky thing is that carbidopa-levodopa technically isn't losing its efficacy. The issue is that there are fewer neurons to work on, which is a trickier thing to deal with. As Parkinson's progresses, there's less of that ability both to produce your own dopamine and to store it. So it looks like it's losing efficacy. The medication doesn't do as much over time, but it's actually reflecting changes in your brain that at this point, unfortunately, we can't control. So the short answer is we do what we can, and there is a lot that we can do, both in terms of medication adjustment and adding different medications to augment levodopa's effect to make it do better what it ought to do for patients. That's what we do as far as levodopa goes. The second question, I'm sorry, Tony, remind me what the second half was.
Sure, it's how do we best address Parkinson's freeze rigid episodes
Right.
in later stages of the disease?
So freezing of gait can be a tricky one. So describe what freezing means. It's a strange thing, but sometimes Parkinson's patients' brains don't let them remember how to walk. So for a moment, that pattern, that habit that's been there your whole life just isn't something you can access. It's like having a word at the tip of your tongue you just can't find. And there are different things we can try to do to connect that circuit again. Now, when that circuit is not working well because of a decrease in dopamine, we can fix that by increasing dopamine via more medication or, again, those same augmenting strategies I was referring to before. Unfortunately, sometimes dopamine isn't the main issue. Then it's harder. Exercise helps. There are different devices that can help also. There are, for example, walkers and canes that shoot a red light across the ground that triggers the brain to allow you to take that step. Lastly, I'm proud to say that the University of Miami is one of the few places researching deep brain stimulation for freezing a gait when these other strategies don't work. That's showing some promise. We have one patient already who seems to be doing well, but there too, we need to see how this develops over time. So it's an important area, and we're looking.
Thank you, Dr. Huck. Thank you, Dr. Marilanda. Dr. Canner, awesome evening. And that was our final question of the night. But Dr. Sacco, before we leave, we would really love some final comments from you.
Sure. Thank you, Tony. Thank you for moderating this important discussion, and thanks everyone and my colleagues for participating. We really appreciate the opportunity to answer your questions, your interest in what we do, and the support of the community. The physicians, neurologists here tonight are really part of a whole great team that we have in our neurology department. We're among really the best in the world. I'm really proud of all the colleagues I have working with. We're over 100 people now in our department. We are committed to maintaining that excellence. We are training the future neurologists of tomorrow, and we're involved with a lot of important clinical treatments. Their enthusiasm, commitment, and expertise really reflect the kind of drive that we need to successfully uncover innovative treatments, cures, and preventative methods in neurology. We can cure neurological conditions, we can prevent them, and we can obviously treat them. Philanthropy helps to ensure that we have the best people and we provide them with the best resources and infrastructure. So we are thankful for many of the great people out there, even some of them listening tonight, and their support for the University of Miami Miller School of Medicine and our department. I want to acknowledge the generosity of the Board of Trustees, the leadership, and thank all of our faculty, staff, and loyal donors. You continue to help us set new standards of care. You inspire us to go above and beyond to find the solutions that will make a difference in patients' lives. Thank you for the time to share my thoughts. Tony, thank you for helping us tonight.
It was an honor, Dr. Sacco, an absolute honor. And thank all of you for participating in tonight's In the Know Town Hall. You know, this has been a remarkable hour. Think about that. The human brain is the command center for the nervous system that enables thoughts, memory, movements, and emotions. Talking openly about our brain health is becoming more vital than ever. For us tonight, we were able to not just discuss these issues, but discuss them with some of the most brilliant doctors in the field of neurology. How fortunate and how blessed are we to have been able to share this with you. I hope you indeed come away feeling like you are in the know now about this topic. Please remember that a full recording of this program will be posted online. Look for that link in the coming days. And in a moment, you're going to see a survey about tonight's town hall on your screen. Please take a minute, and I promise you it takes even less than that because it took me about 35 seconds to submit your feedback, because what that does is help us understand your interest and improve our programs. As always, we wish you and your family good health, stay safe, and remember, from all of us, it's all about the you. Good night.